Yes, hello folks. Welcome to Phil Brown here. I'm joined with medical Dr. Rami Khoury. Absolutely delighted to have him here. We're going to have a discussion here about the opiate crisis in America, what's fueling it. I want to get Rami's feedback on what they're doing in Michigan. Rami's based in Detroit, Michigan. He's an emergency room physician and very well placed to discuss this topic. Rami, how you doing, my friend?
Doing wonderful. Thanks for having me on.
Absolute pleasure. Tell me a little bit about yourself so that the viewers who are watching this can understand who you are.
So I am an emergency room physician, been doing this for about 14, 15 years after my residency training, actually trained in Detroit. I practice primarily about an hour west of Detroit in Jackson, Michigan, which is the biggest opioid crisis city in the state of Michigan, and is kind of on the crux of that 75 I-94 highway corridor between Chicago and then what we see down south. So we've had problems here for a while. Been working on this topic since 2008.
You've been working on this topic since 2008. Tell me some of the stuff you've been doing on it.
Well, I kind of look at it. I got really frustrated with the patients coming in, and initially looked at them probably not a very positive light like the rest of the medical community. And then as I grew to learn more and more about the topic, changed my impression of the patients and how to approach them, and been very successful in that. And I saw a documentary called The Oxy Train that came out back in 2008, 2009, and I tried to figure out a way how to track patients to get them in a safe manner in the right place so they can get their medications, but not just coming into the emergency department to get pills and shots when they didn't necessarily need to. That was step one, and then it just kind of grew from there.
What do you typically see in an emergency room or doctor-type situation? Do you see a lot of patients that come in that you can tell this individual is here for a prescription? Does that happen a lot?
Well, I used to see it a lot more before we implemented what's called prescribing guidelines, and people might have heard of those. They're consistent with the CDC or the Center for Disease Control, and some of what the FDA is saying, some of what the hospital associations and American College of Emergency Physicians are saying. One of the first places in the country that did something very, and it's not to say dramatic or drastic, but really inventive, was the state of Washington. And here in Michigan and in my own department, we tried to model after that a little bit.
Let's talk about the labeling of this epidemic, opiate crisis. And this is a non-partisan issue. This affects people on both sides, whether you're left, right, libertarian, doesn't matter. One of the things that frustrates me as a previous addict myself, or current addict, I'm certainly not on them, thankfully, is the discourse that surrounds opiates in America as if opiates are the problem. When for me, to me, it's the equivalent of blaming the car when it hits the wall. If you don't look at the underlying reason why the car hit the wall, you'll never understand why this is happening. And all that's going to change for me, if we just focus our attention on opiates as the problem, is that the correct approach?
No, it's multifactorial. If you look at any data and literature, and we can use emergency medicine data and literature, when you talk about superutilizers or frequent flyers, right? You heard the term frequent flyers, right? If you look at those in particular, the highest utilization are people with what we call dual diagnosis. They have an underlying mental health issue, and then on top of that, they have a substance abuse problem. And those go hand in hand. Mm-hmm. So most people don't go out there and say, I want to get high, and that's what I want to do for my life. There's always a trigger, and if you don't address the trigger, you'll never solve the problem. You get rid of an opiate, something else will take its place. I mean, this is an economy. This is economy, right? You get rid of pills, and pills become more expensive. What did we see? We saw a trend towards heroin, because they're going to get the fix somewhere or another. They're self-medicating for a reason. And until you find the underlying process of that reason and solve that issue and educate that process, it doesn't matter. Something else will pop up.
And it's so frustrating for me to watch the coverage of this. I mean, I've watched it on CNN, I've watched it on Fox, I've watched it everywhere. And the focus is always on How do we get rid of opiates? As if that's going to solve the problem. And there's very little discussion about, look, why are people doing this? Why is this an epidemic in our society? And are addiction numbers changing? What's behind that? Are they increasing? Because if locking people up works, they should be decreasing. If the policies that we have in place now, where we criminalize addiction, it should be getting lower. If it's not getting lower and decreasing, then there's no correlation between what our policies are and how we treat addicts. Other countries are much more empathic when it comes to treating this as an illness and addressing real addiction rates and actually caring about people beyond optics and political discussion. Why do we not hear this being discussed in the media about what really is the reason why people are turning to opiates?
You know, I kind of always say there is some, I would say, some fault to go around on some of the stuff that came out in pharmaceutical literature 20-some years ago. Some of our federal organizations talking about treating pain and pushing pain, and what we ended up doing without the proper information is treating everything as pain. A lot of things manifest as pain. Depression primarily in a lot of people manifests as pain, and anxiety can manifest as pain, especially in a setting where you don't know what's going on. I can't imagine how people would feel when they're ill in a hospital. They don't understand, they're scared, and the answers, when somebody says my pain is 10 out of 10, what they're saying is I need help. They're not saying give me pain meds all the time. And people miss that. And I think that there is some blame on the medical community that ended up pushing this. We as a society in America, for better or for worse, we don't like to hear the truth. We don't like to deal with pain. And there's a mentality that if I don't think about it, the problem goes away. It festers, and I think it is multifactorial in that regard. And I think the media, they probably want to sensationalize because that's how you get ratings, right?
Sure.
Your entertainment, and unfortunately, I see some of that. But I don't necessarily think everybody knows the correct answer, and any bit of data, they're just putting it out there, and that's what we see.
Yeah, and it feels like almost the data is politically manipulated. So if you do 100 studies and you can get one to show that incarceration works, then someone's going to take that and ignore the 99 that say that it doesn't, and it gets manipulated. One of the things that troubles me about this is that if you're a legitimate pain patient, for example, a lot of people, and I've talked to a lot of people like this, will tell me, I'm almost afraid to tell my doctor the type of pain that I'm in for fear of being seen as someone seeking pills, because there's an immediate paranoia about that, where I need help with my pain, but I don't want to be seen as a pain pill seeker. And there's not with every doctor, to be fair, but I understand that they have to be cautious of this. But I can tell you, having been on the other side of this as a patient, because of the stigma surrounding pain pills at the moment, many patients are afraid to be open with their doctor about their pain because they're afraid of being judged.
I agree with you, and one of the things I have said to patients when they afford me the time to talk to them is, you have to be open. If you're going to want to talk about your pain, you have to have an honest discussion, and that honest discussion cannot start with what only works for me is. And the reason that is not a true statement is...
Do you get that a lot? Sorry, Rami, does that happen a lot?
It does happen a lot. And in very few patients is that a true statement, because what you find is in a lot of patients, other stuff have not been tried. And because other stuff have not been tried, when you say what only works for me is, that becomes a red flag for a provider. And we're taught like that, right? I mean, what I do, for lack of a better term, is pattern recognition. And because you have to recognize the patterns to diagnose things. And with this, the majority of people who are coming in really trying to get not necessarily trying to get a high, but trying not to go through withdrawal, which isn't necessarily the right reason to come in to get a pain pill, will use the exact same statements. They're not lying to you because that does work for them, but they don't know what is out there other than the few medications their doctors have told them about, and those didn't work for them. That's why they're there. But what they haven't seen is a full assessment of everything that can be done to make their pain better, which also includes some cognitive therapy.
Mm-hmm. Yeah, it's interesting. So if you get a patient that comes in, because I was reading something about this, and correct me if I'm wrong here, but there's satisfaction surveys that patients fill out that I think Obamacare mandated these. And if you go into a doctor, a hospital, whatever, and you ask for pain pills, you don't get them, you get your satisfaction survey and you said, I wasn't treated adequately. Does that come back on you and the doctor, and is that partly what's fueling doctors saying you just have to give them what they want?
I will say yes and no. And I'll say yes is the fear that is there. The pain surveys have been around for a while, and the patient experience surveys, and they actually came out during the Clinton administration.
Oh, okay.
And there is, to be reimbursed, think about it this way. You get injured, you end up in an emergency department, right?
Mm-hmm.
You don't know me from Adam. I spend 15 minutes with you, I diagnose you, I discharge you home. You have a broken ankle, you're still going to have pain. Are you going to be happy?
Yeah. No, I mean, of course not.
But the fact of the matter is, did the provider do anything wrong? The provider didn't. So the laws state that you have a right to get a pain assessment, but I have a right to treat you as I see fit as the medical provider based on the assessment I do. And people don't understand that. But when you look at the other piece of the pain survey, it's a reimbursement tool for CMS. And so if you are
CMS, Rami?
CMS is Centers for Medicare and Medicaid.
Okay.
That's the federal payer for Medicare and Medicaid.
Okay.
And if your reimbursement, a portion of that reimbursement, whether for the hospital or the physician side for those patient populations, is based on patient experience. If you see a restaurant that's rated 4.2 out of 5, do you think that's a pretty good restaurant?
So it's a good restaurant.
Okay, in healthcare, 4.2 out of 5 means you're losing money on that patient population because your patient experience scores suck. It's a bell curve. So it's not you have to hit a minimum and all of a sudden you're good. It's a way, unfortunately, to drive this, it's a way to save money. So it's the wrong approach. It helped drive some bad behavior from physicians, absolutely. And there are docs out there that tell you, if I write a pain pill, particularly in an outpatient setting, I'm not going to get a bad review on Yelp or on Facebook or something, etc. Right? And the reviews are what's going to drive the business because it is a business. So there is that fear there, but at the same time, if you as a provider, as a physician, as a nurse practitioner, as a physician assistant, you sit down with a patient, you show real empathy, that you care about them, and you explain the why, you don't tend to see that problem. But that's never been explained to people. I was never taught how to sit down with a patient and explain to them what I can and cannot do and why this is important for them. I was never taught that.
Yeah, that's really quite sad, actually. You work in an emergency room. How, in comparison to previous years, where would you assess the problem right now? How often do you see patients in an emergency room setting that goes back to what we were saying earlier, that are in withdrawal, that need pain pills? How often is that a problem for the medical community?
So I can tell you right now, in my department, we see about 85,000 patients a year. Mm-hmm. We are averaging 1 overdose a day. This is a small community. I work in a city of 35,000. The county's 150,000. I'm seeing 1 overdose a day. I'm the only hospital in the community. We do with our medical first responders, EMS, our police departments, we have naloxone, Narcan out in the community, and they are administering it. We have naloxone, Narcan over the counter that people can get on their own and administer, and those people are not coming in. We do see people who are coming in withdrawal, and we try to get them the right resources, but there aren't enough of those to go around. And it's a consistent problem.
What do you do with someone who comes in that's in withdrawal?
I try to get them plugged into our mental health programs where we can get them involved with our access team, which is our mental health team. And we have an addiction center in the community that I see if we can have, if they have availability there for inpatient stay, if the patient's up for it. If they don't, I try to connect them with an outpatient stay. But in the meantime, I give them naloxone prescription. I give them a prescription for medications to help with the cravings and some of the medications to take the effects of withdrawal off. But I cannot get rid of the withdrawal. And the reality, these patients, that's their fear. That is their fear. They are afraid of withdrawal.
So one of the things that disappoints me, Rami, is there are medications out there that will take care of withdrawal and also prohibit a patient from going home, addressing the withdrawal, and then proceeding to take the drug of choice. Suboxone is one of these drugs. It's very limited as to who can prescribe it. But surely if you're getting patients coming in that are suffering from withdrawal for whatever reason, that's a separate issue, surely you should be allowed to say, I'm going to give you Suboxone.
The problem with that is I cannot follow up on these patients. That's number one. You have to have a license to prescribe it for that specific reason. And then there's another component. It has a massive street value, And I can tell you that unless you're in the right setting to set those up, we have currently, as a society, a lack of people who can do this, let alone the cost of this medication, right? So there are a lot of barriers to that. Now, I've been approached about setting up that kind of program in an emergency department, but the problem is if I can't get them to the right person who can manage this, then I got a problem. And I can't start something that I can't finish.
So if you go to a setting, a treatment center, one of the things when they're giving you this drug is you have to take it in front of them. You have to, and we know what methadone clinics are like. You got to come back every day, right?
Yes.
Or every other day. The way it works in California is your induction is done in front of people, and until you start having clean urine samples, you've got to basically come back every day or every other day. Why can't we do that in an emergency room? Is that just not what an emergency room is for, and this is not a treatment center? But shouldn't there be something that says, look, I know this has a massive street value. I'm going to give you one of these pills right now because one 8 milligram Suboxone pill will kill almost any withdrawal. And what it will do is you will be unable to take any opiate, any heroin, anything for a couple of days before your opiate receptors are free of Suboxone. So it would address the immediate problem, and then you would say, look, you get one other pill, but if you don't go to a treatment center, then I can't help you anymore.
So there's a cost prohibitive component to this. So when you look at
the treatment cost,
yeah. So at any one time, so there are some fallacies in medicine. Emergency departments care for in the vicinity of 140 to 150 million people a year across the United States. We are the catchment for everything. We are there. We are there 24/7, 365. We are always open. We're always there for you. Because of that, there's a high cost to each individual visit. So everybody thinks ER is super expensive. At the end of the day, emergency medicine and what happens through ERs is only 2% of the healthcare dollar. But on any individual piece, if you set this up at a clinic, it is significantly cheaper than setting it up in my emergency department. That's the cost prohibitive component. That is a massive cost prohibitive component. And now I'm using my resources, which are already limited to that extent because I'm holding patients that are admitted in my department. My waiting rooms are full, and I'm using them on somebody who is not, they are in and of themselves having an emergency, but they're not in the greater scheme of things. It's not life and death. And that's where there's some pushback about this. Now, I can envision a great situation where we can start it and then hand them off to somebody. And in emergency medicine across the board, we would love to do that. We just need to hand them off to somebody.
Yeah, exactly. And of course, like we said, an emergency room is not an ideal setting. But if it's 8 o'clock at night and I'm in withdrawal. Where do I go?
That's the thing. You don't have options.
Yeah, so you're going to get these patients because they either have to buy it off the street, which is very risky, or they're going to come to you.
Yeah, so the answer to that is, if you have to understand, there's a double-edged sword with that. If they are always coming to me for every answer, then the rest of the healthcare community doesn't come up to speed.
Of course.
And that's what also has happened. So in a lot of instances, let's think about this. Your kid's got a cold, right? Your kid's got a cold, and it's 5 p.m. Where are you going to go? Yeah. You can't go to your doctor's office. You're going to end up in an emergency department. Your kid's got a fever and a cough, and they're coughing up something yellow. You call the doctor's office, and they say, we can't get you in for a week. What good is that? Where are you going to go? So we are setting an expectation, a standard that long-term as a society, from a cost perspective in healthcare, that you don't want to set. That's not where you want to put the resources. It is a short-term answer, but it's not a long-term solution. Okay. Now, the solution starts with, yes, come to me. I am part of maybe like Kaiser, let's say out like you have in California. You come to me in the emergency department. I start you on it as a first-time piece. You sign an initial contract. My case manager can fax that information over to the treatment clinic that's run by Kaiser, and you show up there in 2 days so you can get started on that treatment. Yeah. Now, that solution works. That is not all over the place, and that is not what that would be a best practice, but that's not what we have. So what emergency physicians are afraid of is that these people will keep coming back, and I just don't have the resources to manage them.
So the opiate crisis, in my opinion, and we covered this a little bit in the beginning, is being fueled primarily by mental health issues, by people that are struggling with different issues in their life and self-medicate. It's almost always about pain. So what is the discussion in the medical community at the moment about what's fueling the opiate crisis? Is there honest discourse, or is there, because I'm just an average idiot. You're a doctor. You know much more about these things than me. Surely there has to be a realization in the medical community. Look, if someone comes in here looking for a pain pill, is it looked at the same way as someone coming in asking for blood pressure medication?
Absolutely not. It's not looked at the same way, and it's frustrating to us. We will refill blood pressure medications. We're not refilling pain pills. We're just not doing it. The problem is this is it's a brain disorder. Addiction and dependence is a brain disorder. The term addiction is a negative connotation because to me, dependence and addiction are two different things.
Very different. Very different.
And in addiction, you are doing aberrant behavior and illegal things to get that medication. Mm-hmm. That's the real difference, and I don't like to label one over the other. And I don't like to treat my patients at that. I like to treat them as chemically dependent on something.
Well, there's and that's an important distinction, Rami, because if you're chemically dependent and you get somebody off the medication, you've got a good chance of keeping them off. If you're an addict, you mimic the behavior of someone who's chemically dependent because you're also chemically dependent. You get them off and don't address the underlying issue, they're going back on it.
Exactly.
That's a massive difference, and that's a difference that's not always understood. Because I hear this all the time. So what do you think will result from this opiate panel in Washington that are having a discussion? And do you think that they will listen to, look, this is opiates are just the available narcotic. This is not really the issue. What do you think will happen as a result of these panels?
So, one, I think in our approach to how we manage pain, it shouldn't be pill first.
Okay.
That's part of it. It shouldn't be, when you're dealing with a problem, you don't take out your biggest weapon to deal with that problem. You save that in case all else fails. That's part of this. That's what does need to happen. That's step one. But that's just a pain management component so we don't have problems moving forward. But what we have to do is we have a massive mental health crisis in the United States.
Yep.
Absolutely massive. We don't have bed availability. We don't have resources to keep maintenance. When somebody comes in with depression, why do we not say depression's a disease like high blood pressure? Look at your insurance carriers. Do they treat mental health the same way that they treat physical health? And why not? That's part of the problem. Look at the availability for beds and resources to manage our mental health patients. We don't have it. When you look at state budget cuts, they want to cut budgets, they cut mental health, they cut substance abuse. Yep. And then that's what you're going to do in a time of depression? That doesn't make any sense.
And then,
it's the exact opposite.
And then, of course, it's the first thing they say when we have a mass shooting in this country. Oh, we've got a mental health crisis. Yes, we do, but you're also cutting resources. So it's just a slogan.
To your point, somebody goes in, unless they have the massive means and resources to not only be put in a long-term treatment program, but then be able to take themselves financially out of the situations that keep leading down that path, right? They don't stand a chance.
I know.
Until you start talking about why did you do this, not you're doing this, this is what we're going to do to fix that, but until you fix the why, you'll never solve the problem. And when you look at these drug cartels, it is a business. Okay, opiates are stopped. What else can we bring in that we can hand to people to give them the fix that they need to solve a problem that we as a society refuse to look at?
So what do you think we learn from history and we don't turn around and say, do you know what, we're gonna both ban these drugs and arrest our way out of this? Or do you think they're going to come with a multidisciplined approach and listen to medical professionals about what really is the issue here? That's a much more difficult thing to do because obviously it requires a lot more resources and it's not politically expedient. It's politically expedient to ban these things because that's a knee-jerk reaction. What do you think will happen? What regulations do you think will change?
I think right now you're going to seeing much more stringent stuff on physicians. You're already starting to see it with state laws that are being passed. And I don't necessarily think that's a bad thing. I think that it'll force the doctors to do the right risk assessments beforehand instead of the knee-jerk reaction of, look, this person has a problem, here, take some pills, go away, as opposed to sitting down and trying to solve that problem. The problem is that takes time and that costs money. And this ties in, when I say multifactorial, you're starting to talk about reimbursement. The largest payer for healthcare in the United States is the federal government. And the federal government does not want any medical association to come out and say you should legalize all the drugs. Because when you legalize all the drugs, there are a lot of things that happens when something is legal versus when it is illegal. From a stigma, from a use perspective, from resources that can come out of that. You can say, I'm going to legalize these drugs and I'm going to take the money in taxation from these drugs to put in resources to help with addiction problem. There are a lot of models out there on a smaller scale, right?
We've seen this in Portugal.
And you see it. Yeah, you see it in Portugal.
Portugal in 2001 had the worst drug problem in Europe. Highest per capita of addicts, and their system was based on ours here in the U.S. They legalized drugs. They changed how you get administered drugs. I think they've got one of the lowest addicts rates in Europe, and their overdose deaths are down dramatically. I don't have the numbers in front of me, but it's dramatic. And they've brought about major change in their society based on this problem, and they treat it as a medical issue, not a criminal issue.
It's been very successful, and if I'm not mistaken, there's a 2020 story on it that came out a number of years ago on this topic. I was really impressed with what they did, but you got to get past stigmas, and there's this concept in the federal government that states, and I have heard this, is that then we've lost the war on drugs, and then you're looking at it completely wrong. This isn't a war on drugs, and this is. What we're trying to do is salvage life. I think and make life better for all of us. I mean, how do we regress as a population with all these inventions, all these great things that we do, but we regress as a population? It's amazing that it's viewed that way.
Yeah, I think there's a lot of reasons for that, and I don't believe a politician in America could get elected today if he was going to run on, I'm going to legalize all drugs. if I get into office.
Well, I mean, I don't think a politician in America can get elected today if they come out and say the truth about anything.
Yeah, I know.
Let's be honest with that.
Yeah.
It's a sad state of affairs, and they're under a lot of pressure, and if they go out and do the right thing, sometimes they'll lose their position. It's very hard. You're not incentivized to do the right thing.
Yeah, and again, this is an issue that's equally as bad on both sides.
And I'll tell you that I have a lot of friends that aren't politicians. I spend a lot of time in our capital here in Michigan. I go to Washington, D.C., and they are good people who want to do well. But when you're not getting the information, the pressures are really hard. It's difficult. I think step one with what you're seeing right now is not going to solve the mental health issue. It's not going to solve our current problem with our current number of people in our society that are dependent on the medication, have addiction. The current laws are in place to stop this from moving forward so we can save a generation moving forward from starting them on this medication. Yeah. But it doesn't solve the underlying issue of what next. What is next?
Yeah, so this is a really important point because there's a huge difference between what's the right thing to do and what's the political expedient thing to do. And that's what concerns me, is that even if you give politicians the right information, they're looking at this like, okay, what's going to get me elected, not what's right, which concerns me because is there really a desire amongst politicians to solve this problem, or is there a desire to exploit it for political expedience? Because Rami, if we go down the road, I heard Jeff Sessions talk about this the other day, and it was a bit concerning, but where they're talking about arresting people. He did say, to be fair, that they needed more treatment centers, which they do. But I'm concerned that what will come out of this is stuff that will appeal to a conservative base.
Well, this is something you said at the beginning. This is a bipartisan issue, and to say that I've heard a lot of conservatives here in the state of Michigan come out and say that this is a mental health problem, and they want to solve it as a mental health problem, and they're trying to force the payers, and they're using a project where they're telling the payers, "Here's your budget for Medicaid," right? And that includes both, as opposed to two separate budgets. Here's your mental health budget and here's your physical health budget. Here's all your budget. And whatever you don't spend on physical health, you better be spending on mental health, and that budget better equal zero at the end of the year. And we want to be seeing more spent on mental health. That's a step in the right direction. I am seeing more now from our politicians, both in Washington and in the state of Michigan, and I'm hearing it from my colleagues around the country. They do recognize there's a problem. They are not sure how to solve it, and we're just starting to scratch the surface. Step one, which I do agree with, is restricting how we prescribe and those things, because what you want to do is have that assessment done up front. If I know, you, John Doe, are super high risk, I might think twice about starting that medication, or say, you know what, let me give you a few pills, let's come back and reassess you and make sure we're not going to have a problem, as opposed to here's 60.
Yeah, I think that will be one of the major changes that will be implemented, is how long you get this medication. However, one of the challenges with that is if you shorten how long you give someone a prescription for, 7 days, this is going to mean that doctors are going to be under enormous pressure to make sure they're refilling prescriptions, because the patient, I can tell you right now, when I was on opiates, Rami, when I got to that point where my prescription was running out in 2 days, I was starting to panic, because the fear of running out of that medication petrifies every addict. And so you are bugging doctors every Wednesday. Like, they just quickly, on Kaiser, when we put in a refill request, you can watch it on the screen when it gets refilled. And we're bugging doctors, and even medicine. So it's going to put huge strain on resources for doctors.
There's a two component to this. The 7-day piece is for acute pain only. So somebody who has properly diagnosed chronic pain, who's gone through the appropriate assessment, who's gone through medication trials and now recommended to be on long-standing opiates, and they are under a treatment program with a physician that's being monitored correctly, it should not be 7 days. That does not make any sense, and there will be ways to get by that. The problem is don't look at everything as face value, and things are being sensationalized. What we have to recognize is that for that chronic pain patient who's appropriately being managed, it's not 7 days. That 7 days is for that patient that just had surgery, or that patient that broke their ankle, or that patient that just had a dog bite. That's what the 7 days is for. It is not for somebody who's being managed on long-term chronic pain for cancer, multiple spinal issues, severe arthritis, lupus. That's not what it's for.
Okay, so the last part of this is one of the things that frustrates me. We talked a little bit about Suboxone, for example. There's a supplement you can buy in head shops, smoke shops, that is notorious amongst the addiction community, and it's called Kratom, whatever it's called. The DEA want to put this on a Schedule 1. Yet this is a drug that is used by many addicts when they're coming off opiates that mimics, it attaches to the opioid receptors in their brain, and it mimics what opioids do, but doesn't give you an opioid high, but it helps people manage their withdrawal to get them off. Why are we depriving people who badly need these resources, who maybe can't afford healthcare but can walk into a head shop and buy this medication, this supplement? Why does the DEA want to ban that?
Because it's not regulated. And so when it's not regulated and you haven't studied the effects, there could be some potential downfall. That's really where a lot of this comes from. So part of the problem with what I see right now when you want to talk about marijuana, I am seeing things I've never seen before, because now that it's being done a specific way, the strength is so much higher than it's ever been, and I'm seeing side effects that I've never seen before sometimes happening.
What are you seeing?
Cyclic vomiting syndrome is, for example. I get patients who use marijuana regularly, and hey, good for them. I have no problems with that. But then when they haven't used it in a few days, or they're using consistently, they will get in situations where they throw up constantly with abdominal pain, and the only thing that makes them feel better is taking a hot shower. And then they get in the hot shower, they feel better, then they get out of the hot shower, it starts again. I've had patients admitted to the hospital for that. So what happens when you don't know what all the potential effects of medication are, I can see a reflex like this. And you can look at any process we do in every aspect of society and question, why do we do it this way? We do it this way because we did it this way for years. We've done it like this because this is the information we had, and a lot of these policies and procedures were set up years ago, and it takes a mammoth effort to change. It doesn't mean what you said is wrong, and it also doesn't mean what they're doing is wrong, but the desired outcome is not correct. It's just not the desired outcome, and every outcome we're getting right now in this country, when you look at health, is predictable. It's predictable.
Okay. So, are you in favor of legalized marijuana?
To be honest, not speaking on behalf of my college, because I'm a counselor in American College of Emergency Physicians. On a personal level, I'd like to see every drug legalized, and I would like to see a different approach, because the current approach does not work.
Very, very.
When anything is taboo, and it's perceived as taboo, you have bad outcomes. We have some of the worst infant mortality rates in the Western world in the United States.
Why?
We have high STDs in the United States because we don't do appropriate sexual education and we don't educate about this. Sex is taboo in the United States, and these are the outcomes of it. We have unwanted teen pregnancies that are higher than Western Europe. Consistently higher than Western Europe. STD rates in inner cities that are higher. It all stems from the same concept and our approach.
That is staggering. I had no idea. It's really, really disappointing. In a country that has got overwhelming resources. That's just so disappointing. Rami, there's so many topics on this that I want to discuss. I want to be respectful of your time. I really, really appreciate you sitting discussing this. As you know, it's touched my life personally, and I think there's so many people out there that badly need help and are afraid to get it. And once you get help, you're forever brandished an addict, and that is when we go into a doctor, it's going to come up on our record that we're addicts, and that's going to affect how we're treated, and that is something that people are very apprehensive about.
Yeah, I don't blame them, and it can negatively impact your life, your income ability, It's not correct. And the reality is, it just makes you a little more of a complicated patient, but I will welcome that patient any day of the week.
Yeah, I can't get life insurance, unfortunately, because of it.
So I will tell you, the biggest, what I see when I see people reach out to the community, and those that make the biggest impact are those have lived it themselves. And I work with a community organization here in where I practice, and they do a lot of great work in outreach, and they have like a concept of a halfway house and all these other resources that are just done within the community, and that's where it has to start.
That is so encouraging to hear that from a doctor, because as many addicts will know, and I empathize with doctors, it's not always seen that way. And we've all been in a room with a doctor where we know we're being looked at as drug-seeking addicts, and that's not the case. Look, I could walk into almost any doctor right now and walk out with a prescription for pain pills based on all the screws and metal and rods and all the surgeries that I've had. But the thing is that that everyone's not in my situation, and I feel bad for people because pain is subjective, and it all depends on how you describe it and how do you tell someone that's not how you're feeling. So I sympathize with both sides, because it's not an easy problem to fix. But nonetheless, it's great to hear voices within the medical community, Rami, that see it from both perspectives, not just from the doctors and the patient, because it's not a fun place to be when you're an addict. So thank you so much, Rami. Keep up the great work, and thank you. I'd like to get you back and discuss this a little bit further. Thanks for taking the time to talk to me.
Anytime. I appreciate you having me on, and I truly value your friendship.
You too, Rami. Thank you so much, man.
Thanks, brother.
Take care. See you. Bye.
Take care. Bye.